Okay, so the central nervous system includes the brain and the spinal cord, and the brain and the spinal cord are surrounded by what are known as meninges, and these are these protective coverings that surround the brain and the spinal cord. The meninges include the dura mater, the arachnoid mater, and the pia mater. The pia mater is directly on the central nervous system tissue itself. Outside of that is the arachnoid mater, and then the dura mater is the outermost of the meninges. Now, the central nervous system also has white matter and gray matter, and the white matter is really composed of axons that are myelinated. That's why it looks white, because of that fatty myelin that surrounds the axons. And of course, the myelin is important for speeding impulse conduction down the axon. Gray matter, this is going to be non-myelinated tissue, so cell bodies and dendrites. In the brain, the gray matter is on the outside and the white matter is on the inside, and in the spinal cord, it's the exact opposite. So the white matter is on the outside and the gray matter is on the inside. So the brain, of course, is in the cranial cavity. It has four major parts. It has the cerebrum, which is this outer portion, has the diencephalon in here, which includes things like the thalamus and the hypothalamus and the pituitary, the cerebellum, which is important for coordinating movements and balance and things like that, and then the brainstem, which is important for more vital functions. So the cerebrum really has 5 lobes. Some people say 6. The book only says 4. You have the frontal lobe, parietal lobes, temporal lobes, and the occipital lobe. And if you pull the temporal lobe back, you'll see another lobe known as the insula or the insular cortex. The blood-brain barrier, this is basically a barrier between the blood and the brain. And it's this system that kind of limits the fluid environment around the brain. And its job is to prevent things like pathogens or anything else that's harmful from getting to the brain tissue. And this is achieved by the capillaries in the brain. The cells, the endothelial cells in these capillaries, have tight junctions between them, meaning they're very tightly joined together, so it's hard for stuff to kind of slip through the cracks. There are also astrocytes. So astrocytes are a really important neuroglial cell of the central nervous system, and they kind of wrap themselves around these capillaries to give a little extra layer of protection. Now, there are some things that can get through the blood-brain barrier quite easily, like oxygen and CO2, which is good, but also things like alcohol and anesthetic drugs and some other things can pass through the blood-brain barrier. Now, the blood-brain barrier is deficient in the hypothalamus, the pituitary, and the pineal gland, and that's because they produce hormones. Hormones have to get into the blood. So here you can see this is the brain tissue. These are the endothelial cells that line the capillaries in the brain, and there are tight junctions between them, so stuff can't get through very easily. So the other part of the central nervous system is the spinal cord. Remember, the white matter is on the outside. These are called columns, and the gray matter is on the inside. And the gray matter is arranged into these structures known as horns. There are anterior horns, also known as the ventral horns, and these have nuclei for motor movements, so nuclei of neurons that will send information out. Okay, nuclei for efferent axons, or efferent neurons. The posterior or dorsal horns have nuclei for sensation, so they are bringing information back to the central nervous system. Lateral horns, these are found in the lumbosacral regions and the thoracic regions of the spinal cord, and they contain nuclei for autonomic function. The central canal, this is literally a canal right in the middle of the spinal cord and the gray matter, and you're going to find cerebral spinal fluid. So here we can see this is the ventral horn or the anterior horn. This is going to contain nuclei for efferent information, so it's going to send information out. These are the dorsal horns. These are going to bring information into the spinal cord, and then the central canal would be right here in the middle. So the peripheral nervous system is divided into the somatic nervous system and the autonomic nervous system. The somatic nervous system controls voluntary functions, like the movement of skeletal muscles. Okay, we can consciously control those things. That's the somatic nervous system. The autonomic nervous system controls things that are involuntary, things we can't consciously control. And this is further divided into the sympathetic and parasympathetic divisions. The sympathetic division, this is fight or flight. Parasympathetic division, rest and digest. The sympathetic division is classified anatomically as thoracolumbar, and that's because it arises from the spinal levels T1 through L2. And its job is basically to increase heart rate, increase blood pressure, dilate the pupils, relax smooth muscle, increase respiratory rate, and some others. But basically, all of the responses that you would want in order to either fight or fly. The parasympathetic division, the rest and digest division, is classified as craniosacral anatomically, and that's because it comes from 4 of the cranial nerves, 3, 7, 9, and 10, as well as the spinal levels S2 through S4. So that's why it's craniosacral. And it's basically going to do the opposite of the sympathetic nervous system. And this is the system that predominates at rest. So it's going to decrease blood pressure and heart rate, and it's going to increase constriction of smooth muscles in the GI tract and the urinary tract. It's going to increase constriction of the bronchioles, bronchoconstriction in the lungs. It's going to constrict the pupils. So it's just going to counteract everything that the sympathetic division does. And again, this is just summing that up. So, like I said in class, there are many, many ways that neurons can become injured. They can be injured through traumatic injury or lack of oxygen, or I talked about excitation injury, which is more of a problem with the peripheral nervous system. I talked about tetanus, pressure increased intracranial pressure, which we talked about with hydrocephalus. So there's lots of ways that neurons can be injured. So multiple sclerosis, this is an autoimmune disease. It's a chronic inflammatory disease. And basically what happens is you have gradual loss of the myelin sheath as well as the oligodendrocytes, which produce myelin in the central nervous system. So this can, you can have manifestations in the peripheral nervous system, but this is really a disease of the central nervous system. So the brain and the spinal cord. So what happens here is you have B and T cells that are reactive against our own tissues, are able to cross the blood-brain barrier, and they recognize self-antigens of the myelin sheath as well as the oligodendrocytes. So what happens is there's progressive damage and kind of chipping away of this myelin, but also you are damaging the cells that produce the myelin, so it's kind of a double whammy. So not only are you losing myelin, but you also can't replace it. And this just progressively occurs. Now, I mentioned in class that there are different courses of MS. Clinically isolated syndrome, this is where you have an initial demyelinating event, but it's not significant enough to be considered multiple sclerosis. And this often comes before the relapsing remitting types, where you have periods of flares and remission, so periods where things get worse and things get better. But clinically isolated syndrome is also often a precursor to secondary progressive multiple sclerosis, which is where you have relapsing remitting types of MS, and that eventually turns to secondary progressive, where it just keeps kind of getting worse. You don't have remissions anymore. Now, primary progressive, this is where you just kind of have a gradual decline, and from the initial event. So you don't have really any periods where things get better. So clinical manifestations, big ones, paresthesias. You'll have paresthesias in the limbs, in the face, and weakness is a big one. Changes in gait, visual disturbances because the optic nerves can become involved. And again, it's going to vary. It's going to vary depending on the clinical course. It's going to depend on how long you've had the disease. It's going to depend on if you're male or female. Females tend to be affected more. However, males, when they are affected, tend to have a more severe clinical progression. Why that is, I'm not sure. So diagnosis and treatment. Diagnosis, history and exam. MRI is important because you'll be able to see plaques. As far as treatment, things like immunosuppressants, corticosteroids to reduce inflammation, immunomodulators to try to kind of calm the immune response. And just try to, if somebody has relapsing remitting type, your goal is to have them in remission as long as possible, and when they have relapses, to keep those periods as short as possible. So again, over here we have a normal neuron with normal myelin sheath. In MS, you have damaged myelin, so you have these slower action potential conductions. And then over here is an MRI where you can see these periods of, or these places of demyelination. These are called plaques. And I showed this worldwide distribution of MS. Clearly, North America is affected for probably a number of reasons. Okay, then we talked about hydrocephalus. So this is when there is too much cerebral spinal fluid in the ventricles or the subarachnoid space or both, and this basically increases intracranial pressure. There are communicating and non-communicating types. So communicating types, these are types where maybe you're producing too much CSF or not reabsorbing enough CSF. Non-communicating types means there's something that's blocking the flow of cerebral spinal fluid. This can be congenital or acquired. As far as causes, it can be caused by trauma, can be caused by infection, can be caused by tumors, can be caused by stroke. A number of things can cause hydrocephalus. The congenital types, the most common cause of congenital hydrocephalus is what's known as aqueductal stenosis. And this is where you have some sort of blockage in this area here. Okay, this is called the Cerebral Aqueduct, sometimes called the aqueduct of the midbrain, also known as the aqueduct of Sylvius. So if this is too narrow, cerebral spinal fluid cannot flow. And that's when you can get a buildup. It can increase intracranial pressure. So I told you to know these ventricles and their connections. So we have two lateral ventricles, and these lateral ventricles are connected to the third ventricle by the interventricular foramen, which is right here. And then the third ventricle is connected to the fourth ventricle by the cerebral aqueduct. And then the fourth ventricle is continuous with the central canal. So cerebral spinal fluid is continually made, it's continually reabsorbed, and in hydrocephalus, too much is being produced, not enough is being reabsorbed, or there's some sort of obstruction that's blocking the flow of cerebral spinal fluid. So clinical manifestations, the congenital types, which you'll see in infants, they will have the enlarged head. You'll be able to see the scalp veins. You'll have scalp vein distension. They'll often have this high-pitched shrill cry. They'll, of course, have bulging fontanelles at the soft spots. They'll have trouble with feeding. Adults and older children, headache, cognitive changes. Incontinence is actually a really important find. Changes in motor function. The list goes on. Now, general manifestations of increased intracranial pressure, regardless of cause, these are things like changes in vital signs, headache again, papilledema, which is the swelling of the optic nerve due to the increased pressure, nausea, vomiting, again, changes in cognition, lots and lots of manifestations. As far as diagnosis and treatment, head circumference, if it's increased, that's going to be suggestive. Also transillumination, so if you transilluminate the head, you will be able to clearly see that there is water, which is the cerebral spinal fluid. Imaging to look for any of these stenotic causes, or maybe there's a tumor that's causing a blockage. And as far as treatment, correcting underlying causes, and also placing shunts. So I mentioned in class, I think probably the most common is a VP shunt, a ventriculoperitoneal shunt, where you run a shunt from the ventricle to the peritoneal cavity and the abdominal cavity to let it drain, which is what's being shown here. So you have the shunt that's placed in the ventricle, typically the lateral ventricle, and that's run down to the peritoneal cavity, so this fluid can kind of just drain into this peritoneal cavity. Generally, this tube's going to be longer because as the child grows, you want it to kind of grow with the child. Unfortunately, these things can become infected quite easily, so they often have to be replaced. And again, over here, these are the typical clinical manifestations of congenital types of hydrocephalus. And then finally, we talked about Parkinson's disease. This is a progressive, not always rapidly progressive, but generally progressive in some contexts, neurodegenerative disorder, and it's a problem with movement. And there are idiopathic and familial types. That's considered to be primary Parkinson's disease, or secondary types. So these can be secondary to things like drug use or trauma, infections. All of those things can lead to secondary Parkinson's disease. So the patho, kind of like a lot of these things, it's a combination of genetic and environmental factors. But what happens is there is a degeneration of a portion of the basal ganglia called the substantia nigra. And the substantia nigra is highly dopaminergic, so it produces dopamine. So what happens is you lose that dopamine production. And of course, dopamine is important for reward and addiction and mood, but also movement. It helps to make movements very smooth. And that's why you see things like resting tremors. You see that pill rolling tremor. You see other problems with movement like bradykinesia, so this slow movement. They'll have a shuffling gait. They tend to have the stooped posture. They'll have a flat affect. They have that mask-like face. Can progress to dementia, dysarthria, problems with speaking, problems with swallowing. So lots of clinical manifestations. Diagnosis, history, and physical exam can take you a long way to diagnosing Parkinson's because it has really characteristic manifestations. So symptoms can be improved with things like levodopa. Also MAOIs, monoamine oxidase inhibitors. So monoamine oxidase is an enzyme that breaks down dopamine in the synapse. So if you inhibit that, you are going to keep more dopamine in the synapse, and hopefully more will bind to the postsynaptic cell. Anticholinergics, those will have a lot of functions, a lot of different functions in the body as far as Parkinson's, especially when it comes to things like oral secretions, but also movement to a degree. Sometimes surgery. So these will sometimes be performed in people that have levodopa-induced dyskinesia. So deep brain stimulation, it's basically placing electrodes into these affected areas of the brain, and it's kind of like a pacemaker for the brain, essentially. A pallidotomy, this is where you put these electrodes in there and you basically destroy these areas of the brain.